I want to say that this morning when I was listening to Dr. Nash's comments, when he pulled up the slide of the 1999 report from the Institute of Medicine to Air is Human, I started getting a little panicky because that was my first point. And then when he started to talk about culture, I said, I'm in deep doo-doo because that was my second point. And then he started to flirt with my conclusion, but he avoided it, so I think I'm still okay. You're going to hear some similar comments. And at least it validated to me that we're on the right track. When I think back to that report from the Institute of Medicine in 1999, what Dr. Nash didn't mention is it said that there were 100,000 lives that were lost every year that were due to medical errors and were preventable. And when that information came out, I was a practicing physician and interacted with a number of executives, and we all discounted that as it wasn't a real number. It's not possible. 4,500 hospitals across the country, we're one of them. We didn't have 20 preventable deaths this past year. We didn't believe that there was hard science behind it. This was in 1999. Shortly after that, I was practicing my trade in the emergency department, and I was taking care of John, a 56-year-old executive. John had the signs and symptoms and had the test that suggested he had a pneumonia. I appropriately treated John and discharged him with follow-up care. Unfortunately, his signs and symptoms and his diagnostic studies were compatible with another condition, and that was a blood clot, and I never considered that. So I didn't start any treatment for John. 24 hours later, John collapsed at home, and he never made it back to the hospital. And I realized there are preventable deaths. I just had my first one that I became aware of. Fast forward to 2007, it's November. I had just been in the role of an administrator, and I got to experience Adam. Adam was an 18-year-old young man with a history of cerebral palsy. He lived in Twin Falls, and he loved athletics. He was part of a close-knit family. His cerebral palsy, he had had a number of brain surgeries and had a shunt. And Adam developed some respiratory difficulties and a little bit of change in behavior, so he came to the emergency department at Twin Falls. He was admitted, and there was concern of how his shunt was functioning. So an appropriate image was done of Adam's brain, and there was a question of, is there an abnormality that might be explaining his problems? And it clearly was more than what the physicians and the specialties that were available in Twin Falls were comfortable with, so they made an appropriate transfer to Boise. Adam came that evening. He was not seen until the next morning by the specialist, though he was seen by the admitting physician. By the time the specialist saw him the next morning, it was too late. Adam was now in trouble. His brain had swollen to an irreversible level. And within the next 12 hours, Adam was dead. We identified with Adam's experience that we were not able to effectively communicate between our sites and even within our sites. In 2007, we didn't give a handoff report about every single patient that we were responsible because we didn't have the capacity. So we gave a report on those who we anticipated a problem, and Adam wasn't one of those. If you think it stops there, fast forward to 2011, to June. This is Janet. Janet was a mom. She was a wife. She was a grandmother and a great-grandmother. She had raised her family in Detroit in the heart of the auto industry. She had moved to California. And at 92, her family had said, "Grandma, come to Idaho." Shortly after arriving, she had a mild stroke and was admitted to one of the St. Luke's hospitals. She was recovering nicely, and Janet needed to use the restroom, so she hit the call light. Staff responded appropriately, and they took her to the restroom, and being 92 from that generation, Janet said, "Please give me my privacy." And the staff, not really knowing what her risk of falling was, they accommodated by closing the curtain and saying, we'll we'll be right here if you need me. Unfortunately, Janet did need them, but it was too late and she had fallen. She was assessed and there wasn't identified any problems. The next morning when the family came, they asked about the swelling on the back of her head and the fact that she didn't seem herself. The brain image that was obtained at that point showed that she was bleeding, and 3 days later, Janet too died. 3 preventable deaths. And I started to realize that 100,000 lives is real. Some may argue about that report. I'm not going to quibble about, is it 100,000? Is it 50,000? Some say it really is probably 200,000 because one is too many, especially when it's preventable. We can do better. You see, part of my role as the system's chief quality officer is to be the keeper of the collective memory and the conscience for St. Luke's. I have a picture on my wall, and they ask, is that my granddaughter? And I say, no, it's someone that we harmed. We can do better because everybody, if you're that one, it doesn't matter what your rate of performance is. If you're the one who is harmed and it was preventable, it is one too many. Healthcare is early in its journey around safety and improving and reducing the opportunities to harm patients. There are some in healthcare that are farther ahead. If we look at Johns Hopkins, they've been doing this for 6 to 7 years. Their burning platform was Josie King. We don't want a Josie King. So we as leaders need to be that burning platform. There are other industries that have decades of experience around making safety a primary focus and what it can do. Think of the nuclear industry in 3 Mile Island. It is much safer today. Think of the airline industry. They are able to perform at a rate of what's called 6 sigma. They have fewer injuries, 1 in a million times or less. But that's not the way they were 2 decades ago. They made a commitment to safety to make a difference. St. Luke's is in its own beginning journey on that journey to reduce harm. Take a look at the safety walkarounds that is being conducted by our board members, by our physicians, and by our leaders. These safety walkarounds are occurring at every site. Our staff are seeing that this is an important issue to our leaders. What our leaders pay attention to is the currency of what's going to make a difference. As was learned in the aviation industry, and we are learning in the healthcare industry, implementing a tool by itself may not be successful. The aviation industry instituted a pre-flight checklist. We did a pre-surgical pause. The tool itself, unless the culture is also addressed, will not have a sustainable change. The organization needs to understand the why. They need to understand how it makes a difference. They need to understand that it is not by itself in its final state. It needs to be continually improved, and it has to be a commitment to doing it. Those are the cultural changes that you have to take on if you're going to make a difference. As a physician, I was trained to believe that I didn't need standardization. That was cookbook medicine. I was well trained, long time. I went through certifications, board certifications, exams. I was competent. I was committed to quality and doing the very best I can, and I thought that was enough. Unfortunately, I'm human, and I make mistakes. As David Nash pointed out, we will never be error-free, but we have the opportunity to be harm-free. St. Luke's vision as an organization is to be a national leader in quality and safety. A critical component of that vision is to achieve zero harm to the patients that we care for. As John and Janet and Adam show, we're not there yet. Unfortunately, I could have gone every year since 1999 and talked about a patient. Yet, we stand at a threshold of opportunity and transformation. There is a collective will among the organization. The staff are engaged and ready. The physicians are leading. And there is a collective belief that the status quo is no longer acceptable. We can do better. And together, with leadership and commitment, we will transform our organization to one that is highly reliable and provides safe care. Our next speaker will give you a detailed story of how we can transform. I have known Dr. Marshall Priest for only 20 of the 35 years that he's been in Boise and been an interventional cardiologist at St. Luke's. He is the current executive medical director of St. Luke's Heart, and in that capacity, he helps oversee the programs and services in Treasure Valley and Eastern Oregon. Marshall earned his medical degree and his internal medicine residency training at the University of Tennessee in Memphis, and then he subsequently went on to the University of Alabama in Birmingham to get his interventional cardiology training. So how does a guy with such southern roots end up being an Idaho spud? Well, it took Bob Lobb from the Twin Falls Clinic and an allergist in Boise named Mitch Gagnier, who were his classmates from medical school, to say, you need to come out and go skiing. So Marshall did. And upon being here, he met the likes of Dr. J.W. Smith, Dr. Kirby Orm, Dr. Rod Herr, and he realized that he had found a special place that had that balance of outdoor adventure and professional excellence. In the last few years, Marshall has developed a newfound passion, which is why at his age he continues to show up every day giving 110%. Marshall has identified the opportunities and the difference that can be made in healthcare quality and safety. The opportunity to make a meaningful difference and to improve every day is the elixir that he drinks from. And today, you're about to experience a bit of that passion. Please join me in welcoming Dr. Marshall Priest.
Thank you, Bart. Thank you, Dr. Pate and Courtney, for inviting me, excuse me, to participate in this summit. What I'm going to talk about has some emotional qualities to it, and being a very emotional person, I'll try to keep that under control for you. And one of the foundational themes of what I'm going to talk about really was characterized by the Blues Brothers. You folks remember the Blues Brothers? Aykroyd and Belushi. And one of their signature songs was, "Everybody needs somebody." And we need each other on this journey that we're on, that we're going to talk about, to high reliability and patient safety. We can't do this if we don't work together. So I'm going to try to show you some of the why, but the question that I'm going to ask you is why not? Why not be a highly reliable healthcare organization? So let's get started. If you know anything about this organization, raise your hand. A few do. For those of you who don't, this is the Pacific Business Group on Health. And it's an organization based in San Francisco. There's 60 employers who are part of this organization. They have about 10 million lives that are covered. To be a part of this organization, you have to have 2,000 covered lives in the state of California. So I want to show you what some of their strategies are and see if you recognize these. Engaging consumers. We hear folks talking about that around St. Luke's, of course. Hey, look at this. Paying for value. You know that's what we're trying to do. Move from this volume-based revenue system to one of value. You know, this morning I just wanted to stand up with some of the things, some of the points that Dr. Nash said and cheer, because he really gave a fantastic discussion and talk about exactly what we're trying to do, and it was a great segue into what I hope I can capitalize on from the wonderful messages that he left with us this morning. How about redesigning care delivery? Are we trying to do that? We are, and I think you're going to hear from others today and tomorrow about population health, which is what Dr. Nash was talking about this morning. That's what we're trying to do in our own care delivery system here. And advancing value-based policy. So I'm just going to leave this with you for a minute, and toward the end of my talk, I'm going to come back to this because we, as a health system here, are trying to move into this space and be a player in this space and a leader in this space. And I hope I'm going to be able to convince you to really get energized about this, energized enough that when you're with your colleagues and your peers and others and our customers, that you are giving them this message. So I show this slide at every talk that I give like this to just leave these names with you, and if you want to write some of them down, you can do that. You can see Dr. Nash's name is there. I would encourage you, if you have 30 minutes sometime, to go on YouTube and Google or put in the search bar the science of safety, or put in the search bar Peter Pronovost and patient safety. Peter is a critical care anesthesiologist at Hopkins. And he is an internationally known physician for patient safety. He has 3 10-minute videos on YouTube that are probably 30 minutes of the most powerful messaging about patient safety that you'll ever see. So I would encourage you to do that if you have a chance. So here are some of the key points that we want to talk about. Safety is a science. It has to be a core value for what we do every day in our work. The medical staff is critical for maintaining and sustaining that core value within our system. We have to recognize, as Bart said, as Dr. Nash said this morning, you know, I trained before Dr. Nash did, and when I came out of medical school, the idea was that I was the boss. I knew more than anybody else did. And making rounds was me writing an order and giving the chart to the nurse and telling the nurse to do it, rather than engaging the nurse in, can you help me? What do you think about this patient? Can we talk about what our plan is going to be? It's entirely different now. Healthcare is a team sport. So, in terms of patient safety, what are we talking about? What is the scope of the problem? And Bart has mentioned this, and Dr. Nash mentioned this to some degree this morning. So, 1 in 3 hospital admissions, there's an adverse event. If you look at the leapfrog data of 1,400 hospitals, those leapfrog hospitals that have an A rating, 4.8% of patients who go in those hospitals for an elective surgery never come out. For the worst performing leapfrog hospitals, 17% of patients who go in for elective surgery never make it out. There was an article published in September, an evidence-based article that suggested this 100,000 patient deaths annually may actually be closer to 400,000, so that the third leading cause of death in the United States of America is being in the hospital, behind heart disease and cancer. Pretty amazing. It's just like Dr. Nash said this morning. Doctors don't want to be patients. They don't want to be in the hospital because they know this. But most people don't know this. So I want to talk a little bit about aviation safety and what we learned from aviation safety and how we can use those things that were learned from a number of air disasters that changed aviation safety, how we can use those in medicine. Some of you may remember this. This was an Air Florida crash in Washington, D.C. about 25 years ago, 737. Landed at Washington National from Florida in a snowstorm to turn around and go back to Florida. It was snowing, the temperature was about 25 degrees, the airplane was improperly de-iced by a contracting de-icing service. Air Florida didn't have that service there. So when they're taxiing out to the runway to take off, the first officer says to the captain, we didn't get properly de-iced, I think we need to go back. And the captain says, I'm going to follow this DC-9 in front of us. You'll recall a DC-9 has two engines back toward the tail, and the heat from those DC-9 engines will melt off the ice and we won't have to go back. So he did that. So the DC-9 takes off, and the water and stuff that's on the wings refreezes. In addition, they did not de-ice the engine de-icing systems, which actually run all the gauges. So as they're on their roll down the runway, the first officer who's looking at those gauges doesn't believe what he's seeing, and he doesn't think they have enough thrust to take off. If you listen to the tape 5 different times, he tells the captain, I don't think we can take off. We've got enough room on the runway to abort this takeoff. The captain didn't respond to any of those. The last thing you hear is the first officer saying, Captain, we're not going to make it. They hit the 14th Street Bridge, and you can see what happened. What happened here? How does something like this happen? It's a system error to start with, but it's a vertical hierarchy. And medicine is known for a vertical hierarchy. That's the way I was trained in medical school, and that's the way a lot of others are. Part of what we have to do in terms of this patient safety issue is flatten that hierarchy, so that no matter who you are in the system, you are safe and comfortable saying something when you see something. Those of you who live out here in the Northwest may remember this. This is probably the most important, quotes around that, air crash that ever occurred in this country. This is United 173 flying from Denver to Portland. It's a DC-8, perfectly normal airplane. They get over Portland to get in their landing pattern, and the captain puts the landing gear down. There are 3 lights that come on the dash, if you will, that tells him the landing gear's locked in place. 2 of those lights came on. The 3rd one didn't come on. The 3rd one had to do with the landing gear under the right wing. There are 3 flight officers here, a captain, a first officer, and a flight engineer. So the captain and the first officer became obsessed with this light not coming on. So they aborted the landing, flew around Portland, and as they're flying around Portland, the flight engineer continues to tell the captain, we're running low on fuel, we're running low on fuel, we're running low on fuel. The captain didn't listen. He never responded. The plane crashed. 10 people were killed. After that happened, United Airlines decided to do something about this, and they went to NASA and said, you've got to help us with this. We've got to change the culture in the cockpit. So they started what's called crew resource management, and all of the airlines in the country but Delta signed on to that, and Delta did about 5 years later. It completely changed the face of airline safety in this country. The bottom line foundational fact here is the same thing that happens in medicine. The problem wasn't necessarily the captain. The problem is the system the captain worked in. This is an example of a number of high reliability organizations. Bart talked a little bit about this. Aircraft carriers, air traffic control, the nuclear power industry. You know, I would remind you, if you've ever flown on United, You know, you can take those earphones and plug into the seat, and you can listen to the captain and the tower if the captain has it on the frequency where you can do that. If you've ever done that and flown into O'Hare or LAX, you remember that really your life is in the hands of the air traffic controller, because he or she is directing all this air traffic at very, very busy airports. And you know, rarely ever is there an accident. And that's because they are a very high reliability organization. On aircraft carriers, if one of the fighters is poised to take off on the catapult, and the pilot gets word from the air wing commander, incidentally, while they're on that catapult, they're at full thrust, so the catapult, so they'll have enough speed when they get to the end of the deck to take off and not go in the water. If the air wing commander calls and says, cut your thrust, the pilot doesn't do it. The only reason he does that is if the deck officer walks out in front of the plane on the catapult and gives the pilot the signal to cut the thrust. Very complex organization that doesn't simplify the processes that they have to do to be safe. So this is a slide here that shows over here the annual fatal accident rate, accidents per million departures. This is 1959, and this is 2007, and this is commercial aviation in this country and Canada in the solid line here. So the very first part of this right here is related to conversion from piston engines to the jet engine. But the rest of this, where you can see this dramatic reduction here in fatalities down to zero right down here, is related to crew resource management and changing the cockpit culture, which has resulted in an amazing improvement in aviation safety in this country. The same thing is true in naval aviation. A similar graph here. In 1954, 776 aircraft were destroyed in naval aviation. In 2008, 15, which is a very high-risk proposition, as you know. So, what about the nuclear power industry? Dr. Nash talked about that a little bit this morning. So if we look at nuclear-powered submarines, and you look at this data right here, 127 million miles submerged, 265 round trips to the moon. There's never been a reactor accident. And these are managed by 20-year-olds. We can't do this in medical care? What's the deal? So, you'll remember this morning, Dr. Nash made the point, we'll never be error-free, but we do want to be harm-free. We're fallible. We're going to make mistakes. It's part of who we are. Medicine is not heroic. We have to do the best we can, but we have to understand that perfection is not the goal. We can never be perfect. That's not going to happen. But we can change our behaviors to be better than we are. And that's part of what I'm talking about here. Most medical errors are actually system errors. So that it doesn't work to throw the doctor or the nurse under the bus, because what happens is usually related to a system that allows it to happen. So we have to change our systems to make people successful so that there's no opportunity to make that mistake. We can't prevent them all. We have to be resilient and be able to respond to them and recover from them. But the behavioral component of this in changing the system is vitally important for our patient safety. So James Reason is a British psychologist, and he's the person who described the Swiss cheese model that you're familiar with, where you have several slices of Swiss cheese and you have an adverse event on one end and an arrow trying to go through the Swiss cheese to come out to a disaster over here. And if the holes in the Swiss cheese line up, that's exactly what happens. He is the author who described that. A fascinating book. He's written a couple of books about this. So it leads me to ask the question, what made it a safe day when we're at work every day? What happened on this day that made this day safe? And how do I make it a safe day? What do I do in my work processes and with the people and the teams that I work with to make it safe? You can't read this, but I'm going to tell you a couple of things about it. This is from the Ohio Children's Hospital Solution for Patient Safety. So right up here it says name game. And very interestingly, in Peter Pronevost's book, he describes an event that occurred when an operating room nurse who had been operating at Hopkins for 15 years came to him one day in tears. And they had this discussion, and she had just had a bad interaction with a surgeon. And she made the point that she had operated with this surgeon off and on for 15 years, and you know what? He didn't know what her name was. How often do things like that happen to us as we are taking care of patients? When we're on the floor rounding, do we know who the nurse is? Do we introduce ourselves to the nurse? Do we say, I'm Marshall Priest, etc.? Does the nurse introduce herself to us? Do we know who our team players are? Do we embrace that personal interaction? Secondly, here is handoffs. We don't have any standardization for handoffs. They're done all kinds of different ways, although we're working on that right now using SBAR. But you know, I look at handoffs like this. There are three things I need to know with a handoff. I'm talking patient handoff, physician to physician. One, what do I need to know? Patient's name, why they're in the hospital, what have they had done, where are they in their course, what are their medications, what are their allergies. And two, what is the plan for today? A CAT scan, just getting the patient out of the bed, an x-ray, a stress test. What's the plan for today? And most importantly, number three, what do I need to be worried about? In your gut, what could potentially happen that we don't think will happen, but I need to have it on my radar so if I get a clue to it, I can intervene and keep it from happening. And last but not least, stop and resolve. We had a situation at St. Luke's several weeks ago where a patient with a surgical emergency was transferred from our Meridian Hospital to the downtown hospital at night by a transfer team that had never been in the downtown hospital before, and were given instructions to take the patient to our cardiovascular operating room. They get off the elevator and come out to a T-hall where they can turn right or left. There's no signage there, none, even though the CVOR is just down to the left. Because of the instructions they'd been given, they went to the right, and they took the patient down to a nursing unit. That nursing unit was expecting another patient at the same time being transferred from our Nampa ED who was 30 years younger than the patient who was being taken down there by, with the surgical emergency. The nurse on that unit looked at that patient come rolling down the hall and saw immediately that this doesn't look like the patient that I was expecting. But she didn't check the armband, and she just said, roll her right into room 1, which is where they were going to put the patient that they were expecting, right? Patient had a cardiac arrest. Fortunately, was successfully resuscitated and got to the CVOR and actually survived the hospitalization and is doing well. But there are all kinds of system issues with how that happened, not the least of which is no signage at the T-hall that tells any provider bringing a patient on a gurney where they need to go. Systems. Systems let it happen. So, boards and executives, as Dr. Nash made the point this morning, which is so true, our boards and executives have to be the leaders for this. Attention is the currency of leadership. Transparency is learning. There's nothing like taking a number of physicians, all of whom do the same kind of procedures, and putting their outcomes up in front so everybody can look at it. Not to throw anybody under the bus, but for the person in that group who might not be doing as well as the others to say, how are you doing that? I want to be as good as you are. Tell me how I can be better. So we don't use transparency as a punitive tool, we use it as a learning tool, and you have to have a trust relationship for that to work. So in terms of leadership and safety, these are things where I think we are and are moving over here. Most importantly, safety has to be a core value for us. It's a dynamic non-event. It's something that we have to have on our radar all the time. It's part of our everyday activity. We are indeed trying to shape a reliability culture here at St. Luke's, of which safety is a core value. And the board and the senior leaders must help us. They must own this. We must have ownership and management at the board level, and the medical staff must promote this safety culture for it to be successful here at St. Luke's. So from the patient's perspective, don't harm me. That's the first tenet that we have in the Hippocratic Oath, is do no harm. Heal me and be nice to me. In all the years that I've practiced at St. Luke's, and as Bart said, I'm in my 35th year here now, I think that our nursing service is probably the best that I've ever seen. And I think that they embrace what I'm just showing you here on the slide, sometimes more than we do as physicians, particularly in the be nice to me. And I've always felt like that we have an opportunity in building relationships. I think we do it well. I think people come to see us because of the way we do that, but I think it's an opportunity for us to even do better. So, on the journey to a high reliability organization, we have to be able to manage risky technologies by controlling the hazards and reducing the probability of high-risk operations causing an adverse outcome. It's a constant journey. It's not something that we climb to the summit and we're there and we're done. It's every day, every hour, every minute of what we do. We have to be able to intervene to prevent errors and failures. And even more importantly, we have to have the resilience to bounce back from that, to analyze very small anomalies and recognize that those small errors often lead to big errors, and don't throw them out the door. Look at them carefully and learn from them. So high reliability theory provides us with a common language to do this. It recognizes, and we have to recognize, principles and practices of these other high reliability organizations that we've been talking about in terms of the nuclear industry, in terms of aviation, in terms of how things are done on an aircraft carrier, if you will. High reliability theory allows our executives to share these concepts, but the most important thing right here is managers and workers who will develop the detailed plans. What that means is you go to the front line. The people on the front line know what is working well and what doesn't work well. So we have to engage the front line. We have to go to the people who have the expertise. That's not me. That's people on the front line sharing with me what they think will work best. We have to change our attitudes about reporting information. We have to embrace people who do report that there's a problem somewhere. If you see something, say something. If you feel something, say something. And if we do that, we will establish and support a safety culture. So, as a high reliability organization, We have to look at these small failures that we call near misses, and we have to embrace them and learn from them. You know, medicine is very complex. What we do is very complex, and we can't make the mistake of trying to simplify it down to a point where we don't recognize and deal with the complexity. We have to be sensitive to operations. On an aircraft carrier, about 10 times a day when they're landing and taking off planes, they have people who walk down the deck to make sure that the deck is clean. A bolt this big, if sucked into a jet engine on the plane on an aircraft carrier, will cause an explosion. You can imagine what that would be like. We have to be resilient, as I said earlier, and we have to look to expertise, not rank, to inform our decisions. And that's what we call principles of anticipation and principles of containment. So, we observe and track these small errors and anomalies. We need to worry all the time about errors. You know, if you don't worry about them and don't think about what could happen, we won't recognize what we could do to prevent something ballooning into a major issue or adverse event. A bad day is a good day. Why would that be? Because from a bad day you learn. Bad days are learning days. We celebrate the good days, but you know, success breeds complacency. We celebrate our successes, but we need to know that success breeds complacency, and we always have to be vigilant. Collective bonds among suspicious people. We have to resist oversimplification because as a complex organization, there are a lot of things that we have to ignore, but we have to be careful about what they are so that we don't ignore these small sorts of things that happen that are indicators of another major event that may be coming if we're not vigilant about being aware of that and intervening when we can prevent something from happening. We have to restrain the temptation to try to drill everything down to something simple when we're dealing with a very complex set of circumstances. We have to have adversarial reviews, which are not to throw somebody under the bus, but to recognize where we have issues with our systems so that we can improve those systems. As I mentioned earlier, we have to pay close attention to our operations. We have to instill a culture where everyone values situational awareness, what's going on around us, what are the opportunities for improvement, where is there a potential for an adverse event to occur, and supply our folks with the resources so they can understand all of that. With resilience, we anticipate trouble spots. We develop a capability to improvise. And you know, to give you an example, a personal example, when I was active doing interventional cardiology and we would have a patient come in with a heart attack, and as you know, what we do is take them to the cath lab, do an angiogram, find where the blocked artery is, put a little wire through that blockage and put a stent in, and most of the time that goes pretty well. And in fact, I would tell you that in all of medicine, there's probably not anything more rewarding than to take that patient who is having severe chest pain, who's very sick, and over a period of a few minutes have them look up from the table and say, wow, my pain's all gone away. Very rewarding. But when it doesn't go that way, it really can get dicey very, very quick. And part of the idea of resilience is being able to have a team available with you who can deal with that with quick studies, swift trust, and just-in-time learning. That exists across what we do in our healthcare system. We have to be resilient to be successful. And we have to let these decisions about processes often migrate to those with the expertise to make them, rather than having a top-down approach, avoiding rigid hierarchies, flattening the hierarchy for patient safety. So just for an example, these are some hospitals in the country that are really considered high reliability organizations. I would point out to you that Memorial Hermann in Houston is a hospital that takes care of most of the indigent in that very large city. What does that mean? Well, those are the patients who are usually the sickest. They don't have a regular physician. They don't have insurance. They don't have regular checkups. They have a lot of chronic diseases. and it's the highest risk population that you take care of. So what I am saying to you is that a large city, county institution like that takes care of that level of risk, that is considered a high reliability organization, certainly means that with the talent and expertise that we have at St. Luke's, that we can achieve that same status. Non-high reliability organizations, this little cartoon here says, this gentleman's in the hospital, and the headline on this paper says, if hospitals equaled flying, there'd be 17 crashes a day. And then he's asking the nurse, I think I'd like to have a pilot do my surgery. Non-high reliability organizations focus on success. Now, we want to focus on success too, and we want to celebrate our successes. But as I said to you earlier, we need to recognize that success sometimes breeds complacency, and we can't let that happen, because when that happens, our guard falls, and the next thing you know, we have an adverse event. There's an undeveloped cognitive infrastructure in non-high reliability organizations, and what that means is that there is less discussion about judgment and reasoning. It's the hierarchical situation of the surgeon in the operating room is the boss, and nobody else can say anything or get their head bitten off. Same thing happens on medical floors. We do want to focus on efficiency, but what this means here is that we can't narrow our focus and try to simplify everything to make it more efficient. We do want to be efficient where we can be efficient without letting our guard down. And there were some examples of that from the speakers that were here just before me, by embracing lean and that sort of technology. Inefficient learning is episodic learning, and what I mean by that is that, hey, we really care about safety, because every time we have an event, we have an RCA and try to figure out what went wrong. That's not what we want to be. We don't want to be an episodic learner. We want to be learning every day in terms of how we can be safer in terms of taking care of patients. There's a lack of diversity in non-HROs. What does that mean? Divergent thinking means when you're looking at a problem, the wisdom of crowds. You've got several people with different ideas about what that problem means and what the solution may mean. Information and communication filtering, meaning that when people bring up an idea or an issue that could potentially be a problem, that somebody along that communication chain decides this is not important and puts it aside. And non-HROs reject early warning signs. That's those small anomalies that I was talking to you about that often can lead to major disasters. So some of the characteristics of a non-HRO: attend meetings and solve nothing. You know, if there was an award in Boise, Idaho, for the organization that had the most meetings per capita, St. Luke's would at least be in the top 5. Huh? In heart and vascular, as part of the OPI process, we decided back in December that all of our subcommittees and all of our managing committees are going from monthly meetings to every other month or every quarter, except for our major board. Actually, our board meetings are every other month as well. So the idea here is that we can get things done on a less frequent schedule and allow our physicians and nurses and administrators who attend those meetings to actually have that time to do their work. Novel concept, right? Conduct briefings and persuade no one. Evaluate proposals and miss the winners. Catch airplanes and miss connections. And I love this one. Shuffle papers and lose a few. We can do better. So, are we an HRO? We're not. But are we on the way? We are. Do we have the talent to get there? There's no question about it. You know, medicine is so different today than when I came to St. Luke's in 1979. It's just a totally different space. And it's been a lot of fun for me and a really intellectual challenge to move from being the person who thought he knew everything to being the person who recognizes that the people that I work with are smarter than me. And that makes me successful. That was tough, but I'm proud that I was able to do that, and I think there are others in our organization who recognize that same kind of culture. So we're on that journey. We can do this work. We've got the people who can do this work. We have the leadership in place. We have an engaged workforce who I think really want to do this. Why not? As I said earlier. How do we get there? We get there by being preoccupied with failure, recognizing our successes and that success can lead to complacency. We get there by being reluctant to simplify everything we do and embracing the complexity of what we do and making our systems work to address that complexity. We remain sensitive to our operations and how we do things. We have a commitment to be resilient, to deal with those issues when the unexpected occurs, so that we have a plan to deal with that. We can improvise. And we defer to expertise. If the expertise is on the front line, we have the front line tell us how to do it, or at least offer us opportunities. We embrace divergent thinking, and we have to continually do that. We have to continually do that every day. Becoming an HRO is not a one-time change, but a continual effort. We have to be highly reliable every day that we work. So, trying harder is not going to get the job done. But changing our systems to make us successful will. This says, and I fully believe this because I've been there, the ability of the physician surgeon to allow himself or herself to become a partner, a team player, rather than a dictator is critical for creating a free and open environment with input from everybody. If you see something, feel safe to say something. So, coming back around now to PBGH. So if you happened to work for an employer that is part of this organization and you need a hip replacement or a knee replacement, you can go to any of these medical centers in the country free, take your significant other with you free, your care is paid for, your transportation is paid for. This is a space that we are trying to move into and be a player in as a highly reliable organization. So how did these organizations get this? Well, they have fewer complications. They have shorter lengths of stays. They have fewer readmissions for these operations I'm telling you about, and they have far fewer redo operations for these things. So to move into this space and be a competitor and be a leader in quality and safety, and to be out there talking to employers in our general area about who we are and what we do, and how we're highly reliable and what our patient safety record is, we have to change our culture. And we can do that. I think we're on that journey. We're clearly in a different place than we were just 2 or 3 years ago. So, from Johns Hopkins, Principles of Safe Design Standardized, we talked about that earlier. About 28 or 30% of what we do in medicine every day lends itself to standardization. We know from many articles published by Brent James and his IHC team that for those things that lend themselves to standardization, if you do it the same way every time, you reduce variation, improve outcomes, and lower cost. The craft of medicine does no longer work, as Dr. Nash talked about this morning. Create independent checks where independent checklists are important. Learn when things go wrong, not who did something wrong, but why did it happen? What did you do to keep it from happening? And even more importantly, how do you measure whether or not you were successful? Divergent thinking is what I talked about earlier. The wisdom of crowds, that's up on the balcony. And then you eventually decide how you're going to attack the problem, what the solution is going to be. And that's convergent thinking on the dance floor or out in the weeds. So the environment that we're in is changing. It's changing in the whole healthcare marketplace that Dr. Nash so eloquently talked about this morning in this journey from volume to value. We're in the yellow box on the way. It's hard. We're drinking from a fire hose. As Ben Quintana said to me a couple of weeks ago, if you think we're going fast now, you better fasten your seatbelt, because in about 2 months we're going to be going even faster. I believe that. So what about the change? Are we a pessimist? Are we going to be whiners? You know, I don't like it like this, but I'm going to come to work every day until I retire. Are we going to be an optimist and say, I'm going to ride this fee-for-service horse till it drops, because I think what's going to happen is all of this volume to value will disappear and we'll be back in the environment that I grew up in and I'll be more comfortable? Or are we going to adjust the sails? And are we going to be successful in this new marketplace? Are we going to be a leader in this new space that we're trying to move to? Are we going to be able to say that our patient safety record is exemplary, and they're as good as these other, and we're as good as these other organizations that we've been talking about? I think we can do it. I'm excited to be part of this. I think we've got the leadership and the people who can help us get there. Everybody needs somebody. We've got to work together to get there. My favorite ending comment from my friend Brent James, an old Yiddish proverb, better has no limit. Thank you very much.
Because Marshall has demonstrated the efficiency of teamwork, we have an additional 10 minutes, and he and I would be happy to field any questions. We are up against the break in 10 minutes, but if there are any questions for either of us, we'd be glad to field them at this time. And there are a couple of mics at each side of the room.
Can you speak more about the culture of safety and some of the work that you're doing with the System QSEC Committee?
Well, under the leadership of Skip Oppenheimer, who in his spare time likes to be a pilot, Skip has identified that clearly the transformation that has occurred in the aviation industry can happen in the healthcare, and needs to happen in the healthcare industry. So, and this is where leadership leads, where Skip comes to this committee, he becomes the chair of it and says, I want to make a difference. And what would that difference look like? What would it sound like? What would it feel like? And so he said, Bart, will you come and do a presentation about culture of safety? So I did. One of the slides said, here are the 7 things that typically trip up healthcare as it relates to safety. So he said, will you come back in the next 2 months and give a presentation about how we perform on those 7 areas as a health system? And we had mixed performance, some strengths and some weaknesses. And then he came back and he said, what would you do next year? And so that was the presentation. And what we really identified is that we can implement tools, checklists, protocols. They worked elsewhere, but if we're really going to make them be effective here, we have to address our culture. People have to understand the reasons why. We have to define what are the basic expectations that we will always expect, we will insist upon. For example, stop the line. That when any person has some discomfort, some uncertainty, has a concern for safety, that if they say, I need a little clarification, we would stop until either they have clarity or the other people have clarity. And we would celebrate and recognize and thank them for doing that, rather than the passive-aggressive, roll the eyes, the evil look, don't ever do this again, or the overt, that's not your place. So we have some expectations. Dr. Nash mentioned about a just culture. Healthcare doesn't report all the near misses and the close calls. We're relatively good about reporting the actual events, but they're kind of hard to not talk about. But if you don't report the near misses, which are 6 times as frequent as the actual events, you're going to miss your true opportunity of what's causing, putting you at risk for these events. So we have to have a culture where we feel comfortable speaking about what occurred, because it isn't about me. I work in a complex environment that I'm set up for failure. As a human being, I'm going to make errors 3% of the time on my best days. So what do we have in place to support me to be successful? So a just culture. It doesn't mean it's a blame-free culture, but we have to be fair about it. That typically it's the systems, at least 85 to 90% of the time it's the systems that set us up for failure, not the individual. And that's a huge transformation from what we've typically had in healthcare. I would also say that we have a lot of opportunity about working as teams. In my world of emergency medicine, boy, I learned in the early stages of my career that if I didn't work effectively with the nurses, they would leave me and hang me out to dry. And that ER is a team-based sport. So, and I think that's very true. We just completed a culture of safety and we're just now starting to see the results. And when I think of the areas like an OR, an emergency department, a labor and delivery, or an intensive care unit, if that area has a score where they don't feel they work well as a team, it's not a question of if, it's a question of when they will have their event. And that's our real opportunities. So that's a couple that come to mind. Marshall, any thoughts from you about a culture of safety opportunities?
No, I totally agree with you. And you know, we have indeed improved a lot based on standardization of what we can standardize because we have learned that those processes that work well when done a certain way decrease variation, as Dr. Nash was talking about this morning, and improve outcomes and lower costs. So I totally agree with Bart. I think this, one of the most important concepts here is having people feel comfortable. You know, I made rounds on one of our cardiac step-down units a couple of weeks ago, and the nurse that I was talking to is actually a PhD in botany who changed her career and became a nurse, and very bright. And we were just talking about, I asked her the question, do you feel comfortable with there are three sets of physicians, three different specialties who round on this unit. Do you feel comfortable being able to raise issues with these physicians when you round? And she said to me, for the hospitalist physicians, I always do because they embrace us, but with others who round here, not so much. The idea here is that with teamwork, we can be better. We need to embrace these other people on the care team. I mean, as physicians, we need to do that because, I mean, how in the world can you, how can you put together a plan of care if you don't have the nurse who's going to be delivering the care for 12 hours that day embedded in the care plan herself and being a participant in putting it together rather than just writing the orders on the chart and giving it to her when she might say, well, gosh, I don't believe we need to be doing this. I think there's another way to do this. We've had a hard time as physicians embracing that kind of relationship, but we're getting a lot better at it now than we used to be just a few years ago. And I think that kind of teamwork lends itself to a culture of transparency, respect, and trust, which will translate into improved patient safety and decreased variation and better outcomes.
Question here?
Thank you. I can easily picture what that culture of safety looks like on an inpatient setting. I think it's a great description of how that works. In the clinic setting, I've got a little harder visualization of what that might look like. We're certainly working on standardizing our workflows, and I think that has some great value, but are there some other things that we should be thinking about in the outpatient setting to help develop that culture of safety?
Frank, that's a great question in the sense that what has been studied is more in the inpatient world. And I will tell you that the survey that was done did not include the clinics, and that is an area that we have to rectify as we go forward. The clinics in general don't have the risk that you're going to find on the inpatient side, but that doesn't mean that there's zero risk. There are meds in the clinics, there are procedures, there are opportunities to have the same issues, but maybe not as frequently. You're not doing the major surgeries, the same consequences, but the same opportunities exist. So having daily huddles, do you have them? Do you do, before a procedure in a clinic, do you have a moment where everybody gets on the same page? After the procedure, do you take 90 seconds to ask 3 basic questions? What went well? What would we do better? And what will we do differently tomorrow? And everybody has a chance to speak, and what is identified is acted upon so that we make a difference and continually get better. So to your point, there is clearly opportunity, and that's one of the areas that we have to identify. How can we be effective in the clinics, but it isn't as well known in the industry as we do know in the inpatient world.
Great presentation, both of you. And Marshall, this is probably for you. We talked this morning about narrowing variation, and I happen to know some of the results in what's happened in heart. Can you talk a little bit about not just the theory, but what's actually happened by implementing some of these strategies in heart and vascular?
Yeah, and many of you know what I'm going to say here because you've heard me say it before and you read about it and you see it on television. Probably the place that I would say standardization has made the most difference is how we treat heart attacks. And this started a number of years ago and continues to be refined. And we define, or we call heart attacks STEMIs, and I'll use that term in explaining this. STEMI means ST segment elevation myocardial infarction. ST segment elevation relates to an electrocardiographic change. But you know, just to give you an idea of the evolution of this, when I came to St. Luke's and a patient came to the hospital with a heart attack, they got an aspirin, they got heparin and morphine, and they were in the hospital for 10 days. And the mortality rate was up in the 20%. And oftentimes they're back in the hospital again within a year or two with another heart attack. That's evolved to the point now where with standardization, at least in the counties where we are, Ada County and Canyon County, these patients are identified in the field. So the paramedics call in and say, I have Mr. Jones at such and such a location with a STEMI, and then we activate the team. And that activation is a standardized process of getting our team there. And the treatment is the same. They'll do it the same way at Magic that we do it here, although the out in the weeds part might be a little bit different, but the whole idea is to get that artery open. So we have a standardized process of how we treat that patient from the time they're seen in the field in terms of the drugs that they get to getting them immediately to the cath lab. Also the same is true if they're coming by helicopter. We have our teams available. So to give you an example of a contrasting situation, a few years ago when we put this process in place at St. Luke's, a group of the cardiologists at St. Luke's embraced this idea of having the interventional cardiologist being the person on call for this. The interventional cardiologist, if you don't know, is the subspecialty trained cardiologist who does this artery opening procedure. Another group in town did not embrace that. And rather than that, they had their cardiologist on call who might not have been an interventional cardiologist to take that patient to the cath lab and do an angiogram and then call the interventional cardiologist at home to come in, which delayed the treatment about 30 minutes. We know that that makes a huge difference in long-term outcomes. So the point I'm making is that standardization of that process, which is the way it is for St. Luke's right now, and having that interventionalist being the one to take the patient immediately and standardizing the process from in the field throughout the hospitalization. And what we do now also is all of these patients are referred to cardiac rehab because we know from randomized trials that their long-term outcome and their quality of life is better. So there's a whole continuum here that we've standardized that we know results in narrowing the variation and improving the outcomes.
And then how many years of national recognition as a top cardiac organization?
Gosh, you know, I'm looking 5. Do you know? Can you hold up? Yeah. I'm looking to Sai because she knows that, and I don't know for sure. It's been 4 or 5 years that we've been recognized as a top 50 cardiovascular center.